Dr. O'Sullivan.
Thanks for having me.
Yes, I'm very excited to have you as a menopause expert and a family physician. I think that you provide, a unique perspective from some of the obstetrician gynecologists or the urologists that we speak to, just in terms of, the women that you get to meet and speak with and sort of what is on the front lines, I'd say, for women. And so, what insights would you share about the women that you see in your practice?
Yeah, I do a lot of teaching in Oregon and Washington, especially to doctors and other clinicians and medical residents and med students. And I always tell them, if we were taught all this information during our training, it would make our job so much easier from a primary care point of view. Because the women that I see, I specialize in menopause now, so I actually end up seeing a lot of women who've tried to get care elsewhere and sometimes have been helped to a certain extent. And then, their own doc might be afraid to go up on the dose or isn't really sure kind of the next steps because they might be having some side effects, so I end up seeing a lot of women who've already kind of started treatment. But in general, in primary care, because there are estrogen receptors on every cell in our body, when they're empty and there's no estrogen sitting in there, we get all these symptoms from head to toe. So from our eyes can be dry, our vision can change, we can have itchy ears and dizziness and lightheadedness, tinnitus. Our heart, we can get palpitations. Our skin can become dry. We lose the collagen and elastin in it, and we can get these weird rashes. And then lots of urinary symptoms, genitourinary symptoms, they're called. So anything to do with the vagina, the vulva, the pelvis, the bladder. And so much musculoskeletal issues. Yeah, so tendon and joint and muscle problems. And when you're in primary care, you tend to see so much of those. That makes up almost your whole panel every day, apart from, things like asthma and other heart problems. And so not having all that information to pull from holds you back, and it means that you end up referring patients to different ologists, rheumatologists, cardiologists, and we're wasting so much of our time, the patient's time, the specialist's time, and money, when if we knew it, we could join all those dots and go, just like we do when someone's thyroid's underactive. We say, you're missing your thyroid hormone. I just need to replace that for you.
Right. And I guess with it's almost revisiting the annual health exam for a woman at a certain age to, have the luxury of time, which I know we don't have in the medical world, but to have the luxury of time to lift the lid on, assessing bone health, heart health, everything at this age is sort of a menopause, well check as you're heading into this phase. What does it look like for you to be able to identify menopause and then, manage this in family practice?
It's really difficult. So I have left insurance-based medicine now because of this, and a lot of us have. So, the reality is the insurance companies have made this situation so impossible to work in that to keep your doors open because of how much they reimburse you for each visit, you have to, instead of being able to see 10 patients a day and give them plenty of time and delve into everything and get to the root cause, which is what we like to do in medicine, you now have to see 30 patients a day just to keep your doors open. Pay your malpractice, pay your rent, pay your staff. And so that is the reality that we're living in. And so when you go into your doctor, you could have somewhere between 7.5 and 15 minutes in that room with the doctor, and it's really, once you start working as a doc, it's very difficult to stop and go off and learn about a whole new topic that you should have been learning for the last 10 years, So I don't know how we fix this without bringing it all into medical education from day one.
Yeah,
You know?
absolutely, and I, I have hope that they will revisit it. I mean, but even talking to some family physicians who are practicing in their 40s and 50s, and they'll say like, our practice has changed, so I don't have younger women anymore, I have more menopausal women, but there's not an awareness that there's anything they could do for them. And so, you know getting that enlightenment, even that there is, and refer them on if you're not comfortable and don't have the time for the education. But it's such a gap in the medical world that it's sort of shocking, but not shocking when you look at the lived experiences of family doctors and the busyness of it all.
Yeah. And the other thing is, I think a big part of this is also um, that these medical schools and residencies were designed by men
Right,
for men,
right, right.
you know? And so I did all my training before the Women's Health Initiative study. Like, we do tend to like to blame the
Yeah.
Women's Health Initiative study for the lack of doctors being trained. But I finished all my training before the Women's Health Initiative study, and I didn't get taught anything about menopause.
And nothing about hormone
Nothing.
therapy.
No.
Isn't that interesting? I think that's a really insightful thing, that the Women's Health Initiative study, which we attribute to, hormone therapy going on the shelves and not, only being associated with risk. And so to know that really the training happened before then that didn't include that is pretty astonishing, really.
And the doctors that I've talked to who did know about it through their training, it was taught to them through a mentor. It wasn't part of the medical curriculum. It was information that was passed on from mentor to mentee. And that's what I can gather from speaking to other doctors who have known about it all the time.
And we both kind of live in this menopause all day world, but, with optimism, do you see a shift in providers having interest in getting trained, an increase in education in the medical world?
I do. Yes, I try to be hopeful too. So, last year was the first year I was invited to speak at the Oregon Academy of Family Physicians annual meeting. And the room was packed. And I could not get out of there. I didn't want to get out of there. I was having the time of my life, but I couldn't. Everyone was so curious, so interested, so angry that this information had been withheld from them for all these years. There were doctors there who had lived through the Women's Health Initiative study, have been prescribing hormones always, who were like, "Hallelujah! Finally, we are talking about this again." And then I went back last week to speak again at the annual meeting, and again the room was packed. We had the longest Q&A session ever. They had to come in and drag everyone out to bring them in because there was no one at the poster session. And just the most incredible questions. Doctors and clinicians want to know this information, and they know that it will make their lives so much easier and their jobs so much easier and make their patients so much healthier and happier.
Oh, that's fantastic.
Yeah.
And I see a great work going on out there of, influencers like Heather Hirsch creating education platforms for doctors and yourself. So it is really inspirational and encouraging to see. For women who are kind of living in the current state of things and don't have access to a provider who has expertise, how can they sort of cut through the noise or end up in a good place in terms of their menopause care? Do you have any advice? I know it's a bit of a loaded question, but.
No, that's okay. Yeah, I have advice. So yes, a lot of women are stuck in that insurance system and they just do not have the money to be paying out for these private appointments. And they may have a clinician who doesn't know anything about menopause. And I find that those doctors fall into two categories. So they'll either be very defensive and say, "Oh, I don't believe in that stuff. If you want to do that, you're going to have to go find yourself a naturopath." That's what I hear time and time again. And then there's the other crowd that are like, "Look, I genuinely don't know much about this. all my patients are coming in asking me about it. I know I need to learn about it. So will you bear with me while I go study up a little bit, and I will try to help you. So they're the
Yes.
two camps that doctors seem to fall into. So if you're lucky enough to fall into the camp where your doctor is open to this, then there was an amazing article written last year by two doctors, Dr. Barbara Levy and Dr. James Simon, and it was called The Contemporary Management of Hormone Therapy. And there's a link to it in my website and on my Instagram link tree. But you can even just Google it, and it's open access. The whole article is available online, and it brings you through the history of hormone therapy and why we should use it and how safe it is. And it's kind of like a little document that you could bring to your doctor and say, I found this online, seemingly it's very helpful. Do you mind if I gift it to you? And that would be a good way to open the door. Another thing to do is, if you know you want to talk to your doc about hormone therapy, just to make a single appointment for that. Because you will find sometimes it's hard to get into doctors. So often you'll try and squash a few complaints into one visit to try and get everything taken care of. But of course, the way the system is now, it's not really possible to do that. So make a single appointment just to discuss hormone therapy, and maybe you could bring that document with you. There are some great books out there. Like you mentioned, Dr. Heather Hirsch, she's amazing. She has a great book. Dr. Louise Newson over in the UK has a great book. And Dr. Mary Claire Haver, fabulous book. So some great reading material out there. And one book that I think everyone should read is Estrogen Matters.
Yes, that is a great book.
Dr. Avram Blooming and Dr. Carol Tavris. I mean, that is just so eye-opening.
Yeah.
And so I think, the other piece of advice I would give is to always use the word trial. If you're going to your doctor and you say, would you mind starting me on a trial of hormone therapy? And then maybe I could come back to you in 3 months and I could tell you if anything's changed. And if it hasn't, we could stop it.
Right.
And if it has, then, that would be great.
Yeah.
And I feel like when you use the word trial, it takes a lot of pressure off you and the doctor.
Well, it really is an interesting relationship between the two, where you want to be respectful of the education, but still, come in informed and get the help that you need. And so, picking the right language can be tricky. So I love that trial notion. I've also heard frame it more in terms of, I'm here for hormone therapy versus what do you think of hormone therapy? So more directly. So I love the, I would really, I would like to trial hormone therapy or something to that effect is really, a blend of the two, I think is fantastic. And so, we often hear too, am I too young to go on hormone therapy? Am I too old to go on hormone therapy? What is the perspective on that right now with the evidence that we have?
So, what we know about perimenopause and menopause is that it is a different experience for each woman. You're just not going to meet two women with exactly the same experience. And we also know that during perimenopause, when our ovulation tends to be less regular and we're not really sure what's going on inside as a woman, sometimes we're ovulating and we don't know we're ovulating, and other months we're not ovulating, but it seems like we are. And so if you were to check blood work, which sometimes we do, but it could look like anything. It could look completely normal. It could look low. It could look really high. So we know when we're trained in menopause that you can't make decisions based on the lab work.
Yeah.
Sometimes it's helpful to have a baseline, but you can't be making your clinical decisions based on it, because
it's all over
20 minutes later, it could have been a totally different number. And so,
though, is there, so, because I think there's some confusion maybe for women a little bit in this space, because when the doctor says, well, you're going to do some blood work, or we need to do some blood work, it might not be so much because of the hormone levels, because they're all over the map, but maybe there's other indicators they just want to check to make sure there's not something else maybe going on, like your blood sugar or your thyroid. Is that fair to say that might happen?
Absolutely. Yeah. When I say checking blood work, I mean all those too. Because, you know, and it can be hormones and those other things that are causing your symptoms.
Right.
So I find in women who are going through perimenopause and menopause, their B12 tanks
Right.
for a lot of them. Their ferritin, their iron stores tank for some reason. And that may have to do with our microbiome in our gut.
Mm-hmm.
And we're not absorbing as well as we used to. Or it could be the foods that we're eating, our diet has changed. But for some reason, a lot of women, when you check their blood work, their vitamin D is low, their vitamin B12 is low, their ferritin is low. And often in midlife, our thyroid can go a little wacky. And so it's really important not to miss those things.
And would it,
And
would it be fair to almost say, I mean, I'm a big proponent of hormone therapy based on the research that exists, based on personal experience, based on, what I see it do for friends and people I know. And so I try to hold a bias and park a bias, but I just have a bias. So I'll acknowledge that. And so would it be fair to say, you get blood work, maybe things seem a little bit wonky in other areas, that the first line at this age of life, 40 woman, her period is still getting it, but maybe a little bit different. Just to start with hormone therapy and see what happens after a little while in terms of, not just her biomarkers, but like her mood is maybe off, and just sort of to settle the nervous system, settle all the physiology going on. Would that be a good sort of approach?
I use it like that all
Do
the
you?
time.
Okay.
Yes, I use it as a tool. So it's a really good diagnostic tool. So I use a menopause questionnaire with my patients, and I ask them to complete it, and then we go through the results together and we kind of get a score. And then I can use that hormone therapy as a tool.
Mm-hmm.
So we do a trial,
Yeah.
and they come back, say 3 months later, and we do the menopause questionnaire again. And so, because often I would find a woman would come back and go, yeah, things have definitely improved. And then they kind of get a bit stuck, like my sleep's a bit better.
Yeah.
I'm not getting as many hot flashes. But when you ask someone to fill out a questionnaire and they get an actual score, and you can see, okay, on palpitations, the first time I met you, that was a 3 out of 3, and now it's a 1 out of 3. So that's a big change.
Yeah.
And so I love to be able to show people in black and white their improvement or lack of.
Right.
If they come back in 3 months and they say, I have the same score now, same for everything, then I get the feeling maybe we're barking up the wrong tree, or we have the wrong dose, but you can figure it out.
Right.
But absolutely.
Right.
It can be a diagnostic tool. It's really helpful.
Well, we always say, like, if you want, because for some things there's not a lot of solid research for, but there is some evidence, and maybe you want to try it. We always say, like, track, because the human perspective on what works and doesn't work is so very flawed. And so, I love that notion of tracking. In terms of blood work, like, would you see if someone's ferritin was a little bit low and then they start hormone therapy, would you kind of see maybe that would rebound over time? Or is that something that you would kind of need to address directly?
Yeah, the ferritin sometimes can be high because ferritin is also a marker of inflammation.
Okay.
So sometimes you'll see a high ferritin, and when you put someone on hormone therapy and their body is less inflamed, you can actually see it go down into the normal range. But if it's low, you don't usually tend to see much of a difference with just the hormone therapy, unless you were altering some dietary habits as well.
Gotcha.
Unless we had said, okay, let's add leafy greens and maybe an iron supplement, something like that. Yeah. But I have never noticed that the iron would naturally go up. Like, I do see it with testosterone sometimes.
Right.
Because if you can help a woman with her menopausal symptoms, and now she's sleeping, she's not exhausted, she's able to exercise again, her mood is better, her adrenal glands and her ovaries often will function better.
Makes sense.
And will pump out more testosterone. Yeah. And so you do see it hormonally sometimes. And also with the thyroid. But ferritin, not so much.
Well, and I think that's what makes the whole thing so beautifully interconnected is the hormone therapy will help stabilize everything, but in the absence of good eating, good exercise, and good sleep, you're really going to miss out on the full impact of your possibility to feel good and longevity.
Absolutely. Mm-hmm. And that's the problem with going to your doctor and them saying, well, you need to exercise and you need to eat a Mediterranean diet. And actually what this woman looks like at home is she's lying on the couch, mm-hmm. exhausted, feels like she's in that first trimester of pregnancy. She's so exhausted. Her mood is really low. And she's not able to get off that couch and exercise to make herself feel better. She's not able to go looking for recipes for the Mediterranean diet and go do that shopping and put that effort into cooking and eating because she feels so bad. Mm-hmm. So often, like you were saying, starting with hormones can really cause that ripple effect where a woman then is able to do all those other, right. Those pillars of health that we need.
Yeah, absolutely. It's sort of getting that it's sort of stabilizing in order to get the flywheel going of everything else, but really just kind of fuel for everything. And so for women listening who are on the couch, in a bad mood, can't really function at work, feel like they're just hanging on for dear life, share some stories of, that you hear with women and sort of how they've come to you and where they are now.
Oh my gosh. Yes, I have patients coming back to me. This is what gave me such a passion, partly for what I do now. It was seeing that change in my patients. Because I have spent, 20 something years starting people on blood pressure medicines, diabetes medicines. Right. No one has ever come back and hugged me and said, you've changed my life. It's just such a beautiful part of the job that I definitely got addicted to. Like, I love it. I love seeing my patients coming back feeling so much better. I can think of one patient off the top of my head who was a young woman and was going through perimenopause very early. She said, even her relationship with her daughter had really deteriorated to the point her daughter wasn't even talking to her anymore because of her mood and her behavior and what she was going through. Her daughter couldn't tolerate being around her. She had a psychiatrist who had her medicated up to the eyeballs, and it wasn't helping her. And all I did with her was start her on, I did try to do a trial of progesterone and testosterone, or progesterone and estrogen, sorry. But she was not able to tolerate the estrogen. The estrogen did not make her feel good. So we said, okay, hold that and just continue with your progesterone. And she came back to see me a few weeks later, threw her arms around me and apologized for not being able to afford to buy me flowers. Because she had wanted to show thanks for the change that she had experienced in her life. Mm-hmm. Just in that short time, she was back spending time with her daughter, and her daughter was enjoying her mom. Mm-hmm. And she had been able to cut down and come off some of her psychiatric medications.
Amazing.
It was amazing. Yeah. It was amazing because so much of what her psychiatrist had been trying to treat was her awful anxiety. Mm-hmm. And one of the first hormones to drop during perimenopause for us is progesterone. And progesterone can get converted to another molecule called allopregnanolone and sits on GABA receptors in our brain, which stimulate rest and relaxation. So they're like anti-anxiety medications. And so this woman had been missing her progesterone for years and developing these really bad symptoms of anxiety and unable to get to sleep. And when I gave her back the progesterone, the anxiety almost went away and she was able to get to sleep again. And that changed everything for her.
It's amazing. It's amazing. Yeah. And I mean, there's that really interesting study that shows the rates of SSRI, antidepressant, anxiety medications that go, up, and then the rates of hormone replacement prescriptions dropping down, and they're almost sort of perfectly a perfect X. And so, for women who just get prescribed these antidepressants without any thought of maybe hormone therapy is really shocking as well, and unfortunate. I mean, I think there's a world for both potentially, but to not reflect on the possibility of hormone therapy.
Yeah, and often we're using polypharmacy. So not only are we giving them something for depression, we're also giving something for anxiety, and we're giving something for sleep.
Right.
So instead of just giving back the hormones, we're using multiple meds, not even one sometimes.
Right. Just keep layering on the medications to deal with the symptom of the other medication. And yeah, 100%. Well, and so we sometimes joke about, the household that has the puberty child and the perimenopause woman in it, and like what life's like in that house. But it really is actually very, very serious, and, such an important time to be present and parent in a space that you want to be in versus, reactive and down and frustrated. And so, it's so important that women understand that these are in fact symptoms of perimenopause, and can sometimes, present as the first symptoms potentially that they do in fact have.
That is vitally important, because you can feel those days flying by when you have kids. And, I think you've probably spoken to a lot of clinicians in this space, Natalie, and I bet all of us nearly have the same story, that we got into it because we went through it ourselves.
I haven't really heard that perspective on this platform. So I have seen it in different forums, but no, and I do love that, because I think it just brings an extra layer of passion and purpose to what you're doing.
Mm-hmm. Like all the, Mary Claire Haber, Dr. Vonda Wright, Dr. Corinne Men, not Heather Hirsch. She's too young. She looks young. Just starting. But like, if you talk to them, they all say that they went through this, and they went looking for answers to see what the hell was going on with their body. And so the same thing happened to me. This is why I fell into this, because I was going through it myself. And I remember, being snappy and irritable, and what my patients, almost all of them, say to me is, I do not recognize myself. I don't recognize myself in the mirror, in the things that come out of my mouth. And it is so frightening for women, and it's so upsetting. It shakes us to our core, really. It
really does, because it just layers on and layers on, because, it's not just the words or the feelings that you're having. It's the fact that you can be aware it's happening and not prevent it from happening, and you're trying so hard and you can't. And so the impact on your self-esteem and your confidence and self-identity is just massive. It really, really is massive.
It is. I would love to see a study, and maybe they've done, I think I've definitely seen some research on this, but I'd love to look into it more. But I'd like to look at all the women who are imprisoned and look back on what their crime was and when it was committed in their lifespan. And, ask that woman, did she have premenstrual syndrome, premenstrual dysphoric disorder? Did she have depression after her pregnancy? Things like that, to get some hormonal insight into how many women are in prison because their hormones drove them crazy.
That's really interesting. I would love to see that done. I can talk to you all day, Aoife. I do want to ask one big topic, because I'm extremely passionate about this, because I often hear women say, oh, I was so lucky. Menopause was nothing for me. And I gasp inside and don't know the right words yet. I've said this to somebody else on the show, where I don't know the right words yet to say, to like shake them and say, like, there's all these quiet risk factors, your heart, your bones, your muscles that are, eroding under your, it was so easy mantra. And so any kind of words of advice for women who feel that they have it easy, and what they need to do to really be proactive about their health, so that when they're 70, they can travel and they can chase their grandkids around. Because I think it's an assumption. And I worry about women and their risk of these massive things if they're not aware of their hormone levels.
Yeah. Oh, this is such a big thing. Um, because very often the woman who will say, I made it through menopause with like a few hot flashes and I got out the other side and I'm fine. And I'll say, well, what medicines are you taking? And they'll say, well, I'm on a blood pressure medicine and I'm on a cholesterol medicine and I'm on something for my sugar, which has gone a bit high. And, those are all directly related to menopause, the menopause transition. So there's a study going on called the Study of Women's Health Across the Nation, SWAN, and there are over 3,000 women in it from all different ethnicities. And it's been going on since the 90s. And the women who were in it started off when they were perimenopausal or just newly menopausal. And now they're all in their 70s. And every year they're followed up. And we have the most incredible, eye opening information from this SWAN study. It would knock you off your chair. It did me when I first learned it. So we can clearly see as women go through the menopause transition, their LDL cholesterol, the one that we kind of worry about, could be detrimental to our cardiovascular system, does a sharp uptick. It's not just aging where you get that straight line, it jumps up around the time of menopause. And so does the stiffening of our arteries, which are in our brain and our heart and our neck going up to the brain. And you start to see that there are changes happening in the brain. Some of them are due to hot flashes and night sweats. And when they studied those women, they put a monitor on their breastbone, which picked up the hot flashes and night sweats objectively. But they did also give them a little marker. And so when they felt a hot flash or a night sweat, they would press the button and it would mark it. And they found out they were missing tons of them, like nearly 40% of them, the women were missing. So you might think you're not having hot flashes and night sweats, but the chances are you probably physiologically are. And then, this lack of sleep that tends to happen, that woman is probably on a sleeping med too, the one who got through no problems. So when you look at the brains of women who you've kind of, everything else about them is all matched up except for they're losing sleep. And you look at the women, everything else about them has been matched up, but these women are having hot flashes. And you can see changes in the brain, like tiny mini strokes.
Wow.
Those add up over the years, And so we need more information, of course. We need to see, does that contribute to Alzheimer's disease? Does it contribute to strokes? Because that's what they are. They're tiny strokes in those areas of gray matter. So I think if a patient came to me for a consult and she said, look, I'm the picture of health, but I want to know about hormones to decide for myself whether or not to use them, I would tell her about how we lose up to 20% of our bone over the menopause transition. And we don't get that back. We just continue to lose it, between 0.5% and 2% a year for the rest of our lives.
Yeah.
And how we lose 30% of our collagen from our skin over those menopausal years. And then what happens to their blood pressure and their cholesterol. So I would give them all that information, show them the graphs and say, you are a great or an okay or whatever candidate for hormones if you decide that that's what you'd like to do. But I feel good that I've given you good evidence-based information, because I think not every woman will want to take hormones, but every woman should know about them. Right.
Exactly.
And how safe they are and what they can do for you. Exactly. So I think that's exactly what you were saying, isn't it?
I think so. And I just love that study, the cardiac study looking at the timing hypothesis where, if you don't take any hormone therapy, if you take it, within 10 years of menopause, and then they look at the differences in the arteries and seeing, that if you do in fact take it in the right timing, that you have fewer arterial plaques and more pliability. I believe it was both, but correct me if I'm wrong in that. And so, I really think as we get more research around this whole timing notion, and the importance of, proactive HRT or proactive lifestyle changes together with the HRT, just so important for our longevity.
Oh, yeah. It's a tool, right? It's a tool in our tool belt to give us a longer, healthier life and to keep us out of a nursing home.
Yes, yes, that's a whole other conversation for another day with genital
Mm,
urinary syndrome of menopause and vaginal estrogen and UTIs and
yeah.
nursing homes.
Hmm.
Yes. Well, Eva, thank you so, so much for your time. I loved our chat today. And I think, it's really important information for all women to know. And we're so happy that you're out there, not just, helping women, but also educating clinicians out there and spreading amazing menopause awareness and education. So thank you.
Thanks so much, Natalie. It's been a pleasure.
Thank you.